Okay, this is the first video on the thoracic spine, and it's going to be about thoracic disc pain. It's worth saying to start that the amount of information on thoracic disc at any level, anatomy, pathology, physiology, anything, is very meager. There's almost no anatomical studies being done on this, and basically they simply liken it to the lumbar disc and cervical disc, which is actually ridiculous considering the huge differences between the lumbar disc and the cervical disc. How this can be like both of them is beyond me. The thing you can say about it is that it is drier, smaller, narrower. There's some dimensional knowledge about it, which really doesn't bother us about whether it's broader or wider or deeper. Doesn't really matter to us at all. The one thing you can say about it is that the thoracic spine is particularly immobile. The ribs do this, obviously. It renders it much less mobile than either of the other two regions, which means that the disc is not under as much mechanical stress as in other places. And so the discogenic pain is much less common, if not rare, compared to the lumbar and cervical spine. So understand that what I'm going to say here is very, very qualified. I'm hoping that more information will either support this or refute it. But right at the moment, there isn't enough information to do anything but work with what we've got. Now, what I've taken this from is from Medscape. And Medscape's a really good site. It's well worth you getting a subscription. It doesn't cost anything. In fact, you can do it without a subscription, but it's more convenient if you've got it. As far as medical conditions are concerned, I think this is possibly the best site you can go on as a professional. Everything's in one place. It's in a fair amount of detail, and they got all sort of multimodal learning, imaging, everything else on there you can look for. I would strongly suggest you go to this. So almost everything that is on this presentation comes from Medscape. And what I've done is I've extracted parts of it, and the parts that I've extracted I've put at the end of this presentation, and you can read these things afterwards. I'm not going to go in word for word. You can certainly read them. Just put the video on pause when you get to the appropriate areas. So on now, let's see how we do. Okay, so here's the link to the Medscape site for this particular presentation. As I say, have a look at it and have a look at Medscape in general. You really won't go wrong with it. So, as I say, not much, and even clinical studies are rare here. They keep mentioning 2 or 3 studies, and that's about it. But from what you can see from these studies, asymptomatic disc herniations are either very common or less common, depending on the way the study's been done. Certainly MRIs seem to be much more sensitive for this. CT studies shows about 11% asymptomatic disc problems, while MRI shows something like 37% asymptomatic issues with the disc. So the preferred imaging study has to be MRI when it comes to looking at this. Symptomatic disc herniations, again, look at these numbers. It is absolutely ridiculous. Symptomatic disc herniations are anywhere between 1 in 1,000 in incidence and 1 in 1 million. So we've got a 1,000 times difference between the upper end and the lower end, which shows you that nobody really knows what they're talking about here. The one number that does seem to crop up fairly frequently on different studies, and as I say, there's not many of them, but neurological involvement, either cord or nerve root, is about 1 in 1 million. So this is extremely rare. It's where you'll also see later on in this that the problem you got is that myelopathy may be the presenting signs of this disease and possibly symptoms, whereas pain is only present in about 60% of these cases. So it may be higher than 1 in 1 million. It's very rare for this to be admitted to hospital. 0.15% of disc degeneration goes to hospital, and surgery only runs between 0.2 and 4% of all discectomies. And again, if you look at this number, 0.2 to 4%, the span is massive, absolutely massive. So it's showing you that honestly, nobody seems to really know what they're talking about with this. Myelopathy is more common in this region, per capita cases than it is in the cervical or lumbar spines. And there's a number of anatomical reasons for this and biomechanical reasons. The first one we've talked about before when we talked about bleeding, I think with spinal manipulation, is that the size of the canal compared to the contents of the canal is much smaller. In the thoracic spine, the contents take up about 40% of the diameter of the canal, whereas in the cervical spine, it's only about 25%. So there's less room in there for a disc herniation or osteophytes to be accommodated by the canal itself. So smaller disc herniation, smaller osteophytes can have a bigger effect. There are ligaments, dentate ligaments, that hold the spinal cord in place. And they're positioned such that the cord really can't move backwards in the spinal canal. So it means that anything encroaching on the spine from anteriorly can't be accommodated well, because again, the dentate ligaments hold it in place. So a disc herniation coming backwards and onto the cord, unlike in the cervical spine where it can compress against the fat, or the lumbar spine where you've got more room there, here there's much more chance of the cord being damaged by a disc herniation or osteophytosis. Now, when you compare these two things, the relative size of the canal and the dentate ligaments, it's quite easy to see why myelopathy is much more common in this region. Also, the kyphosis of the spine tends to push everything backwards. So it makes it a bit more vulnerable to osteophytosis and again to disc herniations. Pathology, again, not well studied. Not a lot of cases studied on this. But what seems to happen, the annular tears do occur, and it's believed that the disc is innervated in the outer 2/3. Although I'm not sure how much of this is based on morphology, and how much of it is based on previous experience with the cervical and lumbar discs. When they say the outer annular fibrosis is innervated, they may be basing this on the fact that the lumbar spine is as well. When they checked on this in cases, in the few studies that have been done, they found that the majority of painful disc problems are because of annular tears rather than herniation. You also get calcification in this disc, which is much more common than it is in the other regions. And it's a result of degeneration and herniation. And this can produce its own problems, and it seems to be a particular problem when they're planning surgery. It's unusual, as I say, the discs are not particularly prone to mechanical stresses, so they tend not to get damaged too often. So you don't get an awful lot of pain for it. The problem you've got is determining whether the pain is discogenic or not. And I'm not sure that the medical profession is particularly adept at finding biomechanical dysfunctions that we see. So you might be in a better position to actually find this out than the physician is. But it may also be that the thoracic discogenic pain is undiagnosed because everybody is expecting never to see one because they are so rare. And this leads to confirmation bias. So it may well be that these are more common than is believed. Trauma is much more common in young patients with discogenic pain, and it seems mostly to be the result of rotation, which makes sense because this area of the spine, it actually rotates more than it flexes and extends. So it's reasonable that rotation may be the mitigating or the primary factor in damaging these discs. If there is a myelopathy, it can be on both sides, even though the pressure may be only on one side, and this seems to be on one side, but this resembles Brown-Séquard syndrome. So you may have three, it may not show up as both legs or both sides of the spine, or it may be one side, depending on exactly where the myelopathy starts, but it can look like Brown-Séquard. If there's no neurological involvement, then the pain can be felt anteriorly, posteriorly, or around the rib cage. But don't believe that pain going around the rib cage has to be discogenic pain. If this is somatic pain, it can come from any painful source. It's more likely to be, if it's going from the spine around to the front, it's much more likely to be posterior column problem or posterior pain source rather than referred from anterior to posterior, because that doesn't really happen very often at all. Causes, the majority of these seem to be by a combination of degeneration, degradation, and about 10 to 20% follow rotational trauma. And it may be that the difference in these numbers may be because a degenerative disc has also been traumatized. So part of this is going to be based on imaging, part of it's going to be based on the history of the patient. Now, as far as treatment's concerned, there is almost nothing specific about treatment. What you've got to do, though, is make sure of the diagnosis. You have to be absolutely certain there is no myelopathic involvement. You have to do long track testing. You've got to look at the Babinski, clonus, reflexes, and so on, and look for this to happen. Now, bladder bowel problems are apparently quite rare with disc problems, thoracic disc problems. So the absence of these should not lead you to believe there isn't a problem. If there is a problem with the bladder bowels, then you should take that as a sign of myelopathic involvement and get it out. But if there's no evidence of bladder or bowel involvement, then don't take that as a no, and there's nothing wrong with the spine. Look for signs. As I say, only 60% of these patients have pain as a presenting symptom. The rest of these are going to have neurological signs and symptoms, so look for them. Because the specific pathology, we know it's a discogenic pain, but the specific pathology is pretty much unknown, how this is causing pain. So I think you've got to deal with it as it presents, and you're going to be, this is a symptomatic treatment, try and deal with any inflammation you believe is present, deal with the pain, rest it, not necessarily lay them down or anything, but use tape and so on, and then obviously rehab. It's a bit of a problem. They're just not very common. They're not well studied. Okay, the rest of this is basically about the article itself. So I suggest you read this stuff, get a bit more information you've got in the video, but go to Medscape. So just run through these. I'll give you a few minutes to read each one of these. I'll get myself out of the way so you can pause it and read it. And as I say, this is basically filling out what I've just said to you. Okay, I hope that was helpful. Take care.